Good afternoon, everybody. I'm Dr. Anthony Levinson, joined again today by Dr. Richard Stramko, geriatrician extraordinaire, for iGeriCare's 30-second live event. And today we picked kind of an interesting topic, a somewhat controversial topic around a new medication for Alzheimer's disease that was approved controversially in the United States by their FDA. So we're going to talk about that drug, what it is, treatments more generally, and also just the controversies around its approval. So welcome, Richard. Great to see you again.
It's great to be back. Good to see you.
So developing treatments for Alzheimer's disease and other dementias is very challenging. There haven't been that many. There's really few effective therapies that have been approved. And those ones, as we'll talk about, are really more around modifying the symptoms rather than modifying the disease itself. So Aducanumab, which I'll put up the name because it's not the catchiest, but Aducanumab, which is sold under the brand name of Aduhelm, is a medication designed to treat Alzheimer's disease. It's really the newest clinical treatment in 20 years or so, but it's one of the few sort of disease-modifying drugs that's been approved for Alzheimer's disease. And as I said, although the U.S. Food and Drug Administration, the FDA, they approved Aducanumab or Aduhelm in June of last year, June of 2021. Its approval was quite controversial. So why don't we start off, Richard, and just do a little bit of a recap about this concept of disease modifying versus symptom modifying for therapies.
Yeah, so I think always just reminding people that they can jump on the iGeriCare.ca website for the lessons we've done already on these topics as well, which review them more in depth. So lesson number 6 is how dementia is treated. But for a quick recap, the most common forms or causes of dementia are related to toxic proteins. There's a number of them, but beta amyloid and tau are the common ones in Alzheimer's disease, or vascular disease, so small blood vessel or large blood vessel. And the proteins or the blood vessel damage will cause neuronal death, or neurons are the cells that cause the brain to function. And so if you accumulate, and that, at least this is our theory, if you accumulate these toxic proteins, in the case of Aduhelm, they impair the supportive cell structures, they impair the neurons, and eventually the neurons can't use glucose properly, and the connections between the neurons break down, and it results in nerve cell death and brain shrinkage. So hopefully the thinking for disease-modifying therapy is that if you can get rid of some of these toxic proteins or prevent the toxic proteins from forming in the first place, then you can hopefully reverse the cell dysfunction, the neuron damage, or prevent it from happening in the first place. And
sorry, go ahead.
And the difference is modifying the underlying process that's causing the cell death, as opposed to symptoms caused by the brain damage itself. So the most common symptoms we always talk about are the cognitive symptoms, where people have some memory or thinking problems, but also people can have psychiatric symptoms like anxiety, depression, hallucinations, delusions, or what we commonly refer to as responsive behaviors, which we covered extensively in other topics. So even if I don't treat the underlying toxic protein that's caused the damage, if it's caused some, let's say, depression, I can still use medications to treat that. Or if they're having really significant behavioral outbursts, we can use medications to treat that. And we even have medications such as the cholinesterase inhibitors that can help with cognitive function.
it's probably good to remind people as well that for modifying symptoms, the use of non-medication approaches, especially for certain types of symptoms like responsive behaviors, non-pharmacologic or non-medication treatments are actually the first line approaches. But again, in some cases, medications are also used to try to address some of these symptoms.
Mm-hmm. And so, I mean, you've got this great graphic up here, which outlines some of the methods that are used to try and remove the toxic proteins from the brain. And these have all been tried in clinical trials. So, for instance, you can provide a piece of the protein to your immune system through a vaccine and help your immune system identify and in some ways eat up these proteins or remove them. And in trials, the vaccines have been effective at getting rid of the protein, but the side effects with respect to inflammation in the brain were too much. And so they were too dangerous to be used. There's been multiple antibody treatments. And so this is an antibody is a special protein that generally our own bodies will produce against either bacteria or viruses or parasites, and they're used to either to identify and target or prevent infection with viruses or bacteria, so your immune system can recognize them. In these specific cases, we can find one type of immune globulin or antibody that targets a specific part of the proteins, the beta amyloid or the tau, and attaches to it and helps your immune system get rid of it. So instead of a whole bunch of different types of antibodies, there's one specific type called a monoclonal antibody that people can create in the laboratory that targets these things. And this is the class of agent that Aducanumab belongs to. There have been multiple trials with other agents, bapineuzumab, solanezumab. So again, lots of MAB drugs, right, that have been successful at removing parts of the protein and getting it out of the brain, but similar problems exist in that, or there was a lack of significant clinical response, meaning the cognition did not improve, the behaviors did not improve, et cetera.
So the MAB or MAB at the end of all of those names is suggestive of monoclonal antibody. Is that right?
Precisely. And they've also been associated with, they're called amyloid-related imaging abnormalities. And so there can be leakage of fluid into the brain. All the fluid in your brain is supposed to be within the cells. And sometimes it can leak out. And the other thing would be small bleeds in the brain itself.
Do you want to speak a little bit about this image, or are we getting away from ourselves and we'll come back to it later?
No, I mean, I think this is helpful in that in order to understand that somebody truly has Alzheimer's disease versus other dementias, you want to confirm that an Alzheimer's protein is actually there. So the PIB stands for Pittsburgh compound B, and you see Flor beta pure. And these are.
So let's start with this the kind of scan that we're looking at. So this is a brain scan. It's a special kind known as a PET scan. Is that right? This is a positron emission tomography. It's a kind of nuclear medicine one, and what you see is the outline of the skull. What's lighting up in the different colors?
Yeah, so you'll see the blue and green is generally the absence of the protein, the beta amyloid protein. And when you're seeing the red and orange, that's more significant binding. So there's a continuum. And these are different slices through the brain comparing that. So if you saw somebody without any Alzheimer's disease, you expect to see very minimal or no uptake. And then the more orange and yellow that's there, the more protein is thought to be there, or the increased likelihood that the protein is there. And so these
This would sometimes be used as a test then to kind of confirm. You would take the history and do the physical exam and say, well, this is most likely Alzheimer's disease. But before you might use a treatment that's targeted to a specific Alzheimer's disease protein, you might use something like this for confirmation. Is that how it might be used, or for research purposes?
Absolutely. And so these have to be created with, I think, particle accelerators. They're nuclear medicine tests. So you need specific highly specialized equipment that only exists usually in larger centers around universities. And these compounds don't last very, very long. Some of them, the PIB lasts around 20 minutes, and I think the fluor beta pure is around an hour. So you really need to be close to the places where they create these molecules. And so they get tagged to the beta amyloid. And when they do the special test, they'll light up if they're there. And if they're not there, then they don't light up. So you'll see the blue. The other possibility for confirming that the proteins are actually there would be to do a lumbar puncture, which is a spinal tap. Other people would commonly know it as. And so if beta amyloid's accumulating in the brain, you'll see a drop in the beta amyloid levels in the cerebral spinal fluid, which is the fluid that supports the spinal cord in the brain itself. So these are two ways that, fairly precisely, much more precisely than just a general guess after a physical examination or an MRI, that somebody actually has the protein you're looking to target. So for Aducanumab treatment, either this or the CSF tests, the spinal tap tests, are recommended before you start therapy.
And yeah, it's probably good just to highlight again that in many cases, for most people living with dementia in Canada, you are not going to get any specialized investigations like what you just described, either the PET scan or a lumbar puncture, unless you're participating as part of a special research study or something like that. Like, this is not the normal standard of care for dementia in Canada.
That's correct. And actually, I did kind of misspeak a little bit. So the MRI tests looking for atrophy or shrinkage are actually quite good at narrowing things down a little bit. But if you're going to be infusing a very expensive molecule that might have side effects, you want to be extra sure.
Yeah, and so let's just to take a step back again. What exactly is Aducanumab or Aduhelm?
So it's one of the monoclonal antibodies that we discussed that targets beta amyloid for removal. So that's second classification of treatment next to vaccines.
And I guess
go ahead.
We do usually preface some of the discussion that while Alzheimer's disease is the most common cause of dementia in Canada, there are a number of other different types of dementia. And is it fair to say that because the Aducanumab is targeting a specific protein that is associated with Alzheimer's disease, it wouldn't necessarily be helpful for the other types of dementia?
That's absolutely correct. So vascular dementia, dementia with Lewy bodies, frontotemporal dementias are definitely not possible. However, there are certain types of some movement disorders. So corticobasilar syndrome is one of the overlaps with dementia and Parkinsonism or Parkinson's-like disease. And 30% of the time that could be caused by Alzheimer's disease. So you might consider, if you did have an efficacious treatment, to do a scan in some of those people, and as well patients or people that have primary progressive aphasias. There's a subcomponent or a subset of those people that also would have Alzheimer's. So you could consider doing additional testing in that situation, and it might be applicable, although I don't believe that any of those subtypes were included in the studies.
Okay. And is there with Aduhelm, is there a particular type of patient with Alzheimer disease that the studies were done with?
Yeah, generally very mild disease. So the cutoffs generally would be an MMSE, a mini mental state examination, which is one of the pen and paper tests, would be greater than 21. The Montreal Cognitive Assessment, again, which is a pen and paper test, would be greater than 17. And then there's something called a clinical dementia rating scale. And that was less than 0.5. So if it's a mild disease, then you'll have a lower score. So it's not moderate or severe people. It's people generally at the beginning of their course, people that don't have any other underlying brain diseases like a brain mass or previous history of brain bleeding, and certainly not younger patients that are pregnant or breastfeeding, which should be very atypical for dementia patients.
So the theory in some ways was maybe find somebody at an earlier stage with a mild Alzheimer disease dementia, where this type of treatment might prevent more buildup of the toxic proteins. Was that sort of the theory behind it?
Absolutely. And it should be said that when you observe people over time, you can see certain changes that happen in the brain before you'll see the actual brain shrinkage and cell death. And you'll see impaired glucose usage, and you can see it on PET scans or cerebral blood flow testing. So you can see things that happened earlier that aren't associated necessarily with the large amounts of protein buildup. So we started all of these therapies initially in people that have severe disease, because that's generally where you start to minimize the risk to harm benefits. And when they didn't work in people that had severe disease, they moved to moderate disease and then mild disease for many of these treatments. And then because they weren't even working in the mild stages, they moved to people that had the genetic forms of Alzheimer's disease. So you know that they're going to develop it at some point, maybe in their 40s or 50s. So trying to start people on treatment even before there's any dementia possible. And unfortunately, we haven't had very much luck. So that is the sense. And the beta, part of it is that this amyloid theory is a hypothesis. It's a very good one. It's well associated with the disease, but there's a possibility that some of these proteins are there accompanying some other process potentially. And so that's why it's not working, or that's not why they're not working.
Yeah, that's true. There are different lines of thinking around what the association. We have talked about and maybe simplified things by talking about toxic proteins. That might be what we call an association rather than a cause. There might be something else, and then these toxic proteins are just like a marker or a final common pathway, but are not necessarily the actually sort of pathological or disease causing issue. So then even if you're removing them, if they're not necessarily the underlying cause, you might not see much of a difference. So how does it actually work? What kind of drug is it in terms of like how often would one take it? How would you take it? Is it expensive? What else can you tell us about Aduhelm?
So it's an intravenous medication. All the monoclonal antibodies that we have in use are usually an intravenous infusion. So you'd likely go into a hospital, not dissimilar to chemotherapy, and get an infusion. There are a number of doses. So that looks about a 7 to 8 dose paradigm where you get them over 36 and weeks or so. And so they're about a 1 hour infusion that you'd get. So you'd go in relatively infrequently, but on a regular basis and get this 1 hour intravenous infusion. It costs several $1,000s. So that's per infusion. So if you're getting 8 infusions and if it's working for you and you're tolerating it, the idea is that you would stay on it over time and monitor for some benefit. Also, because of the complications that we mentioned before, or potential complications with the amyloid-related imaging abnormalities, they can be asymptomatic. So you might not know initially that you're having them. So around between the fourth and fifth doses, you'd be looking to get an MRI to observe for those changes to make sure they're not taking place. And obviously, if they're there, then you most likely stop the medication at that time. So it's intravenous, it's expensive. It's not a daily medication, but it's going to be a fairly significant commitment. And then there's the ongoing follow-up and monitoring for any potential side effects, which are not uncommon. In some cases, 20 to 40% of people were developing these imaging abnormalities, which could, depending on where they happen, have a very wide array of symptoms.
So, so far this medication has only been approved, last year in the US. Can you tell us a little bit about what all the controversy is exactly surrounding Aduhelm? You talked about some of the challenges with it in terms of cost and investigations and things like that, but its approval was pretty controversial, wasn't it?
Yeah, I think it's helpful to contrast it to a medication like the cholinesterase inhibitor, so Aricept or donepezil, the same medication being common. When you do pen and paper tests, it improves global memory and thinking. It improves a neuropsychiatric battery of tests, so the kind of anxiety, depression, hallucinations. It improves people's day-to-day functioning. So that means you're more likely to do your day-to-day activities on your own. And then subjectively, if I'm a clinician and I look at 2 people, one who's on the medication or one who's off the medication, I would rate the person who's on the medication as doing better, even if I was blinded to it. So these are kind of direct functional clinical outcomes that the medication causes an improvement on when somebody's on the medication versus not in a randomized clinical trial. So it's a hard endpoint. It impacts your day-to-day life. It impacts how somebody experiences their dementia, and it impacts how the person with dementia interacts with their caregivers. Not a miracle drug, as we've described before. The benefits are modest, but they're definitely repeatable over large populations, multiple randomized clinical trials. So we have a robust evidence that there's benefit. In contrast, Aduhelm doesn't have any of those direct benefits. They used a surrogate marker, which was not dissimilar to the other medications that I mentioned, the removal of amyloid. So you're putting a very expensive drug into play. You're putting somebody at risk for side effects only for a surrogate marker, which doesn't directly impact that person's life. So that's controversial. And I think I'm not intimately familiar with the FDA drug approval process, but there was a committee of 12 people, and it sounded like 11 people voted against it, and the FDA decided to approve it for special authority, based on this surrogate endpoint, which, as I mentioned, other drugs have reached those surrogate endpoints in other studies, but were never approved. So it's very perplexing. There are many people that, because of that, including myself, are highly skeptical. The European Union did not approve it either. So that it's not always perfect one-to-one approval processes for drugs, but it makes more sense that they would reject it. And Canada is currently in process right now of reviewing it. So yeah, I'm not sure what will happen there, but that's the controversy.
Just a quick sort of refresher, I guess. Drugs go through various approvals. This is actually from the U.S. Food and Drug Administration, or the FDA. You start out with what's called the preclinical phase that might involve studies with, animals or basic science research where the drug is developed. By the time you move into the clinical phase, you have different phases. You might have a phase 1 with a very small number of healthy volunteers that take a drug. And then you might move to phase 2, where you have, typical patients. And then phase 3, where you would actually do clinical trials or studies, things like that. And all along the way, things are being reviewed. Then you sort of move on if it's approved to how it's labeled and blah, blah, blah. And as you said, that in this particular case, kind of bizarre because it was not a new type of drug. There'd been other of these monoclonal antibodies tried before. Presumably they were not approved because those lack of hard endpoints, like just removing the amyloid, was previously not enough. But for whatever reason, it seemed to go through. And as you said, Europe hasn't approved it. There's been a lot of, I think, neurologists in the US who have said, well, this is, just doesn't make sense. And I don't know, I guess the other one is whether insurers will cover the cost in the US system. So I guess in the Canadian landscape, you can still have a situation where it's possible that our group that reviews drugs, the Health Canada, one, they might not approve it based on the data, which is not that compelling, and the fact that other jurisdictions have, like European, have not approved it. But I guess there's also the issue of cost. And even if it were approved, it doesn't necessarily mean that the cost would be covered by provincial drug formularies. Is that right? There can be a dissociation there as well. So it could become approved and available, but it would be pretty hard to pay for or access.
I think you saw a similar situation to Avastin, which was a VEGF. It's a blood vessel growth inhibitor used in cancers and colon cancer in particular. And that, it was approved by, Health Canada. Just the payment for it was not. And so you were stuck in that kind of interesting go-between because the provincial payers did not think that it was, the benefits were worth it. So I think all the points that you made are extremely valid. And then, would you want to pay $25,000 a year out of pocket if you had less evidence than a medication like donepezil, which is covered?
I think the other thing, just to sort of add to the controversy, that after the FDA approval, which was, I think apparently 3 of the members of the committee resigned after it was approved. So kind of weird. You have this committee of 12, 11 vote against it. The drug's approved anyway. And so 3 of those committee members resigned, even though it had been tested and approved only for those with early stages, as we talked about. Initially, the FDA said it could be used for patients with any degree of Alzheimer's, but then within a few weeks, they actually kind of recanted on that and walked back the decision. Again, kind of strange. And now they've sort of come out and said, well, the manufacturer of the drug has in like 7 years or until 2030 to conduct more studies that actually have some of those endpoints that you talked about before. In other words, to really prove that it is effective. So kind of an odd story. I don't really understand the ins and outs enough. So
there's a part of me too. So and this is why people are so cynical or skeptical of big pharma companies, right? And rightfully so. When you see things like this happen, sometimes at this stage, I wonder if there might be a secondary motivation in that, pharmaceutical companies can only spend so much on each disease type and mechanism. And so they have to hedge their bets, right? They're going to do a lot of research and see if it works out. And there's been so much money spent on research and development of new drugs in the last 20 years. in terms of all these biologic molecules that are coming out, very interesting, pathways and stuff. So I wonder if there's some sort of, throwing the dog a bone kind of thing happening as well, where they're like, well, we might have to start approving something so people don't throw their hands up in despair and stop the research. I don't know.
I guess the other angle on that as well, that's a good point. The other angle is, there have been so few advances with respect to such an important condition as dementia that there could also have been, behind the scenes, maybe patient advocacy groups that might be saying, well, you have a potential treatment and we haven't had, a novel treatment for Alzheimer disease. Maybe there was some pressure in that sense to have approval of an agent for, let's be frank, dementia research in North America and globally, there's probably a significant underinvestment. It's why part of our new national dementia strategy in Canada includes more investment in dementia research, because there really have not been a lot of drugs approved for the various types of dementia.
I mean, and even to that point, I mean, I think the approval in the budget was $50 million, right?
It was still relatively small in the big scope of monies that go to.
And to put that into context, depends on what you read, but between $500 million to $1 billion to get one new drug completely from lab to market. So when you put that in context, yeah, absolutely, there's not a lot of investment taking place. And not to, I don't want people to despair as well, because there are a lot of building blocks that have been put in place in the last 20 years that have helped us refine our understanding. Let's say the molecules that we showed for PET scanning, where you can actually look at somebody in real time and understand that they definitively have beta amyloid pathology without, doing a post-mortem studies. Like, that's really important components to the research and building blocks. And there's cerebrospinal fluid analysis and other markers you can test in the blood and so on. And what you were mentioning before in terms of non-pharmacologic interventions, community supports, like the medications are one side of it. But we've talked about this before, in that people live with heart failure. It's not like you reverse heart failure, but people look at it a lot differently than they would. And it's less stigmatized, than dementia is. And so there has been a lot of advancement in many ways in the understanding and management. It's just not getting rid of those pesky toxic proteins yet. So I still have hope.
Let's go to some of the questions that have come in. So here's one that was sent in earlier this week about one of the other medications you mentioned, called rivastigmine. And the question is, how effective is rivastigmine to manage primary progressive aphasia? Are there any drugs to help dealing with primary progressive aphasia? And are there research studies in Ontario that we can volunteer to join? So maybe just start off with a quick overview of primary progressive aphasia, and talk about rivastigmine and whether there's a role there.
Yeah. So primary progressive aphasia, aphasia is an interference with your speaking abilities or your language processing abilities. And so primary progressive aphasia is when the first symptom of a dementia is a language problem. So people may stutter or have really effortful speech or halted speech where they take pauses. There are other types where people may not understand words or object meanings anymore. And there are what's called logopenic type, which is most commonly associated with Alzheimer's, where you kind of get the tip of the tongue or word finding difficulties. And you might talk around certain topics instead of being more direct. And so there's three types of primary progressive aphasia. They're associated with different proteins, and sometimes they'll evolve into a different type of dementia. So there's no drug approved for the treatment of any of the primary progressive aphasias. If you did think, however, that there's an underlying Alzheimer's disease, Alzheimer's disease that's responsible, then you could consider using one of the drugs that's approved to treat Alzheimer's disease, such as a cholinesterase inhibitor or memantine. But that's off-label use, and it's more the clinical art as opposed to hard science. There's a Canadian consortium on dementia research, and there are different centers. So there is one here at McMaster, in London Health Sciences, in Toronto at Baycrest, and even in the Kawartha Lakes, there's a research network there. So I'm not sure of a specific study for primary progressive aphasia and drug trials happening right now, but those are some areas where you could inquire about research studies.
The Alzheimer's Society of Canada, I think, has a section on their website for people who are interested in potentially participating in research studies. And it might also be reasonable to check with your provincial Alzheimer's Society as well to find out about any research studies. But I think what you mentioned is good. Look for a local academic center to find out if they have a particular type of research studies. And then if there are clinical trials or clinical studies that people are looking for participants, often those will also be advertised through the Alzheimer's Society of Canada on their little research section, or the provincial Alzheimer's societies. Another question that came in was around, does the treatment of cells cure dementia or Alzheimer's?
Right. And I think that gets to kind of what we've discussed so far, in that whether it's treating these toxic proteins or getting rid of them with a vaccine, with a monoclonal antibody, or with one of the enzyme inhibitors to prevent formation of a protein, we haven't successfully been able to treat the cells and get rid of the toxic proteins, or make them better in other ways with more supportive treatments like antioxidants or things like that reduce cellular damage. So unfortunately, not quite yet.
There's I don't know if I think it's from a separate person who sent in something. I guess there's a book by the motivational speaker Tony Robbins, a book called Life Force, that talks about the value of the T cells from the placenta potentially being helpful. But again, I don't think there's any sort of hard studies, like research studies or clinical studies. Again, that's a little bit more of a speculative thing, talking about, the types of cells from the placenta. And even, I think it's been appreciated over the last 10, 20 years. It used to be that people thought brain cells like neurons were pretty static. And once they're there, if they get damaged, that's it. I think there is a little bit more appreciation of what we call neural plasticity now, that, brain cells are a bit more dynamic than that, and they may respond to change and things like that. So the concept that there could be, cell activity after damage, I think that's one thing, but this is definitely more speculative. There have been some work done, I guess, with fetal implants for some disease states. I don't know if that's still actively being done in Parkinson's research, for example. There was a bit of a time where there was interest in whether there was any role for sort of new cells being implanted in areas that were damaged. But to my knowledge, that's not being done at all in treatment for dementias. But you may know differently.
No, it kind of got to the point too. Like, again, not to be too cynical, but I would say, like, if there's definite treatment, you'll know about it right away. It's going to be all over the news. It's going to be everywhere. If there's high quality scientific evidence, like, it's going to be in your face. It's going to be all over the newspapers. So, I wouldn't get too fussed about the smaller stuff. And I definitely wouldn't go to Tony Robbins' book for scientific evidence on that side of things. I'd be cautious around that. And we catered this to the disease modifying therapy because that's what Aduhelm is, but then just kind of flagging to people as well. You can modify your dementia risk significantly by the non-pharmacologic brain health activities like exercise and maintaining blood vessel health. So check out the iGeriCare lesson on maintaining brain health for more specific activities you can do then. That a lot of that stuff is helpful for preventing people's risk, up to 30 or 40% in some cases. So definitely
that's an amazing point about things you can do now to promote brain health. That are there's a lot more evidence that surrounds some of those primary and secondary preventative strategies, many of them lifestyle changes, but there are also, certain medications to watch out for, certain medical conditions that you can make sure that your treatment is being optimized. And, those are things that have been shown to help prevent dementia, or at a minimum, maybe slow down its progression if you're looking after some of those other variables. The only other caveat that I would say is, the media does also tend to maybe exaggerate, one study or the miracle breakthrough. Right. And so the other advantage of being, more patient is understanding, sometimes they'll emphasize an animal study, and it might be, a decade or more or never right. until that agent actually is shown to be clinically beneficial too. So
no, that's a great point. Yeah. They'll overcall things. I think that was kind of my point, is like, you'll hear about it, even if it's not that great, but certainly if it is that great, there's going to be a huge hoopla created around it. So so some of the other questions that have come in, do you think Health Canada will approve Aduhelm for Canadians? And also, do you know of any clinical trials in Canada right now where Aduhelm is being tested? So I'm not sure. I would guess no. I don't think they will approve it, but who knows? It's really, really a toss-up. You can't predict the future. So I wouldn't try, but I don't think they should.
We have you on this live event because of your future predicting abilities. So
right. Sorry. I didn't want to disclose that to everybody. Yeah. Yes, I'm clairvoyant. Yes, absolutely. Yeah. And then there's
something to work on.
Exactly. Yeah. In the spare time, right?
Yeah.
So and I don't think there's any clinical
I don't think there's any. I don't think there's any clinical trials right now.
Yeah.
I can't predict the future either, but I think from a financial standpoint, in terms of, risk, benefit, and cost, I doubt it. But
I like it. I like your definitive.
My definitive speculation.
Well, it's more definitive than mine anyway. So good for you.
You mentioned a few of them, but somebody was just asking, can you review again what are the current medications or other medications that are currently available, I guess, to be used for symptoms in Alzheimer's disease?
Yeah, so all the cholinesterase inhibitors are approved for mild, moderate, and severe dementia. So that's donepezil, rivastigmine, and galantamine. They have slightly different dosing. Some are twice daily, some are once daily. Some have a little bit more of an indication for treating Alzheimer's, and then some are maybe a little bit better for other types of dementia. I know for sure that, they're covered in Ontario and BC. Most provinces cover them, so there's no out-of-pocket cost, which is nice. And there are some side effects, but again, modest benefit. And then for moderate to severe disease, there's memantine, which is an NMDA receptor antagonist. And so that's thought to, in theory, decrease some of the toxic processes that happen in the brain. And so that's moderate to severe. And there is some thought too, there's not great evidence that you could even combine them. So it's not exclusionary. but memantine is not covered generally. So
I don't think it's covered on any of the provincial formularies. I guess some people might have super duper insurance coverage where they might get some kind of partial coverage if they had separate sort of drug plan coverage. But
and some people, the most often I'll use it if people have a contraindication to cholinesterase inhibitors, so their resting heart rate's quite slow, or they've had a lot of stomach issues, or they have low weight or weight loss. Generally, I won't start somebody on a cholinesterase inhibitor, but if they have the financial means and they have moderate to severe illness, then I'll definitely start them on it. So I have a number of patients that are just on memantine.
Okay. We have time for one final question, and the question is, what about environment and stimulation? Does lack of stimulation affect progress? And I guess this might be like social, mental, and physical. And, I think the pandemic has actually highlighted the ways in which social isolation can, in fact, exacerbate dementia. And I think there have been studies from several jurisdictions where they have shown, in general, a worsening of progression of dementia with social isolation. There's not a ton of data, but there is some that suggests that increasing social activity as well as social and cognitive activity can help to promote brain health. But it's not sort of as compelling data with respect to like randomized controlled trials. Of course, it wouldn't be entirely ethical to randomize people to isolation, much as people have had to endure it during the pandemic.
Yeah. I think I remember when we were doing the review, like the WHO brain health stuff, just how large of an impact that had with respect to like even heart attacks and death, right? The social isolation, it was not a small effect. So we're humans. We need that social interaction. It's a big deal for sure.
And I think what we haven't necessarily sorted out in our society are some of the best ways to actually, promote those environmental and stimulation factors. But I think it is, good to keep in mind that, many jurisdictions have adult day programs or may have, special programs for people living with dementia and their care partners. So again, checking in with your community recreation centers, local YMCAs, dementia societies, Alzheimer societies. Those are all helpful places to look to continue having some degree of ongoing social contact and environmental stimulation.
Do we have time for one last anecdote?
Sure.
So I in BC, when I practiced there at St. Paul's, the clinic space was organized around the central area where people would receive kind of support from a physiotherapist. And there was group physiotherapy classes for people. And I had this one gentleman who was particularly grumpy and not a big fan of mine, who had mild to moderate dementia and just pushed back so hard against any kind of supports coming into his house or any medical support. And we did not have the best relationship. But finally, after pushing from his son, he came into one of these physiotherapy classes that would happen on a fairly regular basis. And then, one day I'm like walking by and there's a group of them and they're all singing the same song from like, the 1950s, all of the patients there, older adults, really enjoying each other's company. And this guy had this huge smile on his face, just enjoying himself. And, his son would talk about what a big difference that made. So it's funny, right? Again, medications, super expensive stuff. And you're like, get together with some people, do some exercise and sing some songs and it'll change your life, So there's that side of it too. Don't underestimate that aspect of it.
No, that's a great way to end. So I want to thank Richard again for a really stimulating discussion about an interesting issue. iGeriCare was developed with support from many partners over the years, the Center for Aging and Brain Health Innovation, which is powered by Baycrest, McMaster University, the Jarvis Center at Hamilton Health Sciences, the Hamilton Health Sciences Foundation, and the Alzheimer Society Foundation of Hamilton Halton, and our division of e-learning innovation, continuing to work from home. And reminder, I'll put it up one last time. In our on our iGeriCare site, the little donate button in the top right helps to provide ongoing support for iGeriCare and for these live events. So we do very much appreciate your help and support. The next live event we'll be doing mid-April, Thursday, April 14th. And the topic is care of the cognitively impaired people in the hospital. There is a survey pinned at the top of the comments section. We always appreciate your feedback and suggestions for future live event topics. And once again, thanks to the team. And as always, teamwork makes the dream work. Thank you again.
Thank you.